Good evening and welcome to Health Check. My name is Grace Mutiso. Joy to be with you in this new week, and we are set to have a great program lined up for you. Today we are focusing on pregnancy and related complications. You want to be a part of this discussion today because we have two great doctors in studio who are going to help us understand that. So what's pregnancy? You know, what are some of the complications you can encounter, and how do you need to take care of yourself if you experience any of the complications? And you know, I was just thinking earlier today, one of the things or desire for a couple when they get married is to have a baby, you know, to get pregnant. But I'm not sure if anyone tells us that pregnancy can come with complications. So today, that's what you're going to sort you on, and invite you to be part of our discussion. 22232 is the SMS line. That is 22232 is the SMS line for any question that you have. You can also call us live. The numbers will be right at the bottom of your screen. You can go online on Facebook and YouTube. We are also live on those platforms via the handle at Hope TV Kenya, and you can drop there your question and comment. We'll be getting back to you on that as we proceed on with the program. Allow me at this point to turn to my doctors and allow them to introduce themselves. It's always an honor if the guest introduces themselves. How are you, Doctors?
Hi.
Hi.
Okay, because we are two ladies in studio, so let's start with the man. India, we are the majority. Daktari Karibu, how are you doing this evening?
Thank you. I'm great. Thank you very much. Had a busy day, but we thank God for all that. My name is Dr. Wachira Murage. I'm a consultant obstetrician and gynecologist working at Savannah Healthcare Services and at the Kenyatta National Hospital. And it's a pleasure to be here.
Okay.
Thank you.
Karibu sana.
Thank you so much, Grace. My name is Dr. Karen Muthembwa. I'm a resident in obstetrics and gynecology at the University of Nairobi. I'm very grateful to be here. I'm also based in Kenyatta. Yes.
Thank you. Thank you for finding time to join us. So let's start by just defining, you know, it's easy to assume everybody knows what pregnancy is and its complication. Maybe we'll start with Dr. Wachira. Help us understand, so what's pregnancy and what's complication related to pregnancy?
Thank you very much. Pregnancy is God-given and is supposed to be normal, because it's a desire and, for everyone, for a couple to have a child. But little do we know that sometimes when you're blessed with a pregnancy, the journey begins. And that journey is a long journey, okay, of about 10 lunar months, all right, about 280 days. And anything can happen, all right? And this anything is what you're talking about, complications of pregnancy. And they can occur, the first stage, the first period of labor, what we call the trimester, then the second and the final one. So there are several complications or things that can go wrong, a variety of them. There are so many, we might not exhaust them in one program. But there are many, and sometimes they can snatch us, that joy that we have. So that's pregnancy, conception, when an egg and a sperm are conceived in the fallopian tube, and they go into the uterus and start growing now as a baby. So anything from bleeding, from miscarriage, and further on, pressure, other diseases like diabetes, hypertension, up to the pregnancy coming out early, labor coming out early, and even issues surrounding delivery. All those are complications of pregnancy.
Okay. Yeah. And Dr. Karen, let's speak bleeding. Yeah. Break it down for us. How can it be complicated in pregnancy?
Wow. In fact, it's very good that you've picked bleeding, because bleeding is the #1 cause of death in pregnant women all over the world, and more so in sub-Saharan Africa. So any bleeding is usually not a good sign. You don't want to have any bleeding in pregnancy. Sometimes there can be spotting depending on the time of the pregnancy. If it's an early pregnancy, they might have something like a spot, which might be the actual sign of pregnancy. That might not be a really big problem. It might just be the implantation. But actual bleeding is, you know, when there's a lot of heavy pervaginal bleeding. It might be quantified in terms of the pads or whatever they use to protect themselves from the blood. So if you change your pad all the time, that can be not a good sign. So hemorrhage can occur at any time during the pregnancy, early, mid, and also late when you're actually in labor. In early pregnancy can be due to either a miscarriage or there are different types of miscarriages, really. So depending on which one, you can also experience a lot of bleeding. During mid-trimester, now that's the second trimester, there can also be some form of bleeding, and there are several causes that can cause that bleeding. At the end also, when you're delivering, there's bleeding either during or even after delivery. So that one we're very, very careful about.
Oh, and Dr. Wachira, you know, Dr. Karen has just talked about bleeding. It could happen before, it could happen during, it could happen after. So what causes, for example, bleeding before, during, and after?
Yes, thank you. As my colleague has alluded very, very well, and she has said you can divide the bleeding in early pregnancy, the first trimester bleeding. And most of these are the ones that sometimes lead to miscarriage. We do not quite understand some bleeding that occur in the first trimester that normally lead to miscarriage or pregnancy loss. Sometimes we think maybe it's genetic, and therefore maybe after fertilization something happened. Sometimes it could be the placenta, all right, that did not attach properly. And just to caution, because there are many ultrasounds done, and we have heard of subchorionic hemorrhage.
What's that? That's
because we see patients coming and telling us, I was told I have subchorionic hemorrhage. It has really become a term of the recent times, and this is where you have a bleeding below the placenta, where the placenta is attached. And if that bleeding continues, it can dislodge the placenta. So placenta causes. Some of the bleeding and that may lead to miscarriage would be due to hormonal causes, progesterone, all right? Because in the early pregnancy is normally supported by progesterone until further on, maybe after the first trimester. So if a pregnancy did not form enough progesterone from the placenta, then it means that it will not have good support, and therefore it will die off and start bleeding, and then end up as a miscarriage. And that is why we see as doctors, my colleague here and others, we normally say, we are having unexplained bleeding, we are having threatened abortion. It's like the pregnancy wants to come out, because the causes are quite elusive, up to and including some local causes that may occur just around the cervix, cervicitis infection. So these are some of the causes in the first trimester that can cause that, and we generally call them, threatened abortion. And the management for that, normally we just expect. Once we support the pregnancy with the progesterones, we give folic, then we move on and bed rest. We hope that that pregnancy is going to be okay. When you're looking at now the second trimester, as Doctor has said here, is that other now causes can come, including now the placenta location, okay? And further on, you can have even the placenta separating, all right? And the placenta being low-lying. That means it is below the baby. So these are some of the causes, and sometimes, as you said, they pose a lot of problems because we do not have a definitive treatment. It's expectant management. Further on, the placenta also carries the day when you're going now to the third trimester, and they continue being a leading cancer of bleeding, up to and including uterine rupture, especially just before labor for the ladies who had previous cesarean sections before, and others with other problems. So we have those as the common, various causes. There are many, yes.
Okay. Dr. Karen, you talked about, the number of pads that you change or whatever material you're using to sort yourself down there. A lady might be asking, so how many is it after I've changed 3 or 5 and I'm pregnant? That should be a telltale sign I need to rush to the hospital.
We usually say any bleeding, it's important for us to know, because even that small bleed might be the beginning of the bigger bleed. So even if I give 3 or 5, still that's quite a bit by the time you're changing your pad that much. It's always important to say or call your doctor and tell them that you're having spotting or bleeding. In the early trimester, that's when we expect there could be some bleeding, as Dr. has talked about, especially for those ones just very early when there's attachment of the placenta. At that point you can get a bleed, but that can happen. But later on, if you have any bleeding, it's always an important sign and you should tell your doctor. Yeah.
Okay, thank you for that. Our great viewer, we are talking about pregnancy and related complications today on Health Check. And remember, you can be part of our conversation on 22232. That is 22232. That's our SMS line. Also, we'll be opening up our phone lines in a short while. The numbers are right at the bottom of your screen there. You can call in and ask your question. And also, you can check us out on Facebook and YouTube via the handle at Hope TV Kenya. Ensure you share this content so that it can help somebody else who is watching. And thank you for that. So let's move to miscarriages, another complication in pregnancy. Let's start with Dr. Karen. So when can I say, okay, now I've miscarried this child?
Yes, that's miscarriage. Basically, is there are different types of miscarriages. As Dr. has talked about, the first and most common one that you'll probably get is either a threatened abortion. We call them abortion. We still call them abortion.
That word, eh?
But nobody wants to. Nobody wants to call it an abortion. But in our medical books, we still use that. You know, it's because of the taboo and all that.
Yeah.
But allow me to use it for now.
Yes.
So there's something called the threatened abortion. That one, it means it's threatening to come out. So that's one of the usual causes of bleeding. It's also one of the causes of bleeding. But there's another one called an incomplete abortion. Now this one is when the pregnancy has started to come out and has already, there's some products that have already gotten out, and then there's some that have remained. Now that's called an incomplete abortion. There's another one called a complete abortion. That's when all the products have come out. Usually a patient will come having said they bled, and then now the bleeding has stopped and the symptoms of pregnancy have gone, and maybe they don't have any pains or anything. And then there's another one. There's a septic abortion. Now that one is when it's infected, when there's an infection and then you start having bleeding, and then you have something that looks like an incomplete abortion. Parts of it out, some of them are still in. There's also there's usually another one called missed abortion. Very common. You don't know that you are pregnant, or you might have known you are pregnant, and then in the middle of the pregnancy, when you do a scan, the pregnancy is not viable.
Yeah.
So it's already in but has not come out, but it's not alive. So that's another type of we call it abortion, but yes, a miscarriage. And then of course there's the clandestine one, the one people do outside and then come when they're already complicated. So now these are usually one of the other causes of death in pregnancy, and you should note them. Most of the time they will present with hemorrhage. Yeah, they'll start having bleeding, or they might have abdominal pains, and they will always come to the hospital. And when we examine, we'll find what type of an abortion it is. But most of them either threatened or incomplete abortion.
Dr. Wachira, you know, I talked about it. Dr. Karen said about abortion. Yeah. I've heard that term. I cringe a bit because, you know, if it's abortion, ule mama aliabort. You know, it's like a taboo. Yeah. For a lady could be watching and they've been told you need to abort this child.
Yes.
So just help them understand when they use the term abortion. Yes. What does it mean? What's the process that lady needs to go through?
Yes, thank you very much. As Dr. Karen has effectively alluded to, when you're talking about abortion, miscarriage, abortion is any pregnancy loss before viability. So you're talking about where are you practicing, or where are you In our setup, we are talking about 28 weeks, basically. That's about 7 months.
Yeah.
Yeah, so any pregnancy lost can fall into that category. Where in other countries, you might find maybe 26 weeks, yeah, or about 600 grams, may survive. So anything less than that is what now would be classified as an abortion. So when a patient is being told that you are going to abort, although that term is very, very sensational, so we normally don't use it a lot. So we say maybe termination of pregnancy, yeah, for medical reason. Yeah, for example, as she said, you can have a missed abortion. So a pregnancy that probably was not viable, yeah, but you are not able to discover it, yeah, until further on, you are still thinking you are pregnant, but you do a scan and told, oh, you are thinking you are 9 weeks, and maybe the pregnancy died when you are 4 weeks or 5 weeks. So that's the missed abortion. I told you are terminating a pregnancy. So termination can be two-way.
Yeah.
The clandestine, of course, now that is what is a bit very, very debatable, and we do not want to go that direction. And then, of course, you have the medical, which you are advised by the doctor that this pregnancy is not viable for some reason, or maybe you have a very, very serious illness like a cardiac disease, a heart disease, or maybe you have a cancer, a sort of a cancer that is advanced, or even if it is not advanced, the pregnancy is so young, all right, and you need to treat the cancer, and therefore this pregnancy has to be terminated so that you can treat the cancer. So these are some of the reasons that someone can be advised to abort or terminate a pregnancy for medical reasons, and the law is very clear, the medical reasons for that.
And is there a trimester that is dangerous that women should say, this one I need to be careful so as not to have a miscarriage, or it can just happen?
When you're talking about miscarriage, we're restricting, just we have said, below 28 weeks. All right?
Yeah.
After 28 weeks, you're talking of a delivery. It's actually a pregnancy, because you're talking of a baby of about probably 800 to close to 1 gram as you go to 30 weeks. So that is a baby that you'd expect can survive. Yeah. So from thereafter, it is a delivery. All right? Yeah. Below 28 or 7 months, now that is a miscarriage. And this is where now, the people should worry. As Dr. Karen had said earlier, when you're talking about the first trimester up to around 12, 13 weeks, those ones will normally be very, very spontaneous. And we do think pregnancies at that time are not viable themselves. All right? Yes. Something went wrong. Just like we said, maybe genetic, maybe they didn't have enough progesterone, maybe the placenta was insufficient or had a problem, and therefore those pregnancies, we use the word die, okay, and then they can come out. Thereafter, yeah, that she talked about mid-trimester miscarriages. Yes. You're saying that the pregnancy is viable. So if it has to come out, then we think of maybe the cervix is not tight enough. This is what we call cervical incompetence. That the cervix was weak, and therefore as the pregnancy was becoming heavier, it is then aborted, miscarriage, this is a spontaneous pregnancy loss. And therefore, all the time when a lady is pregnant, the first and part of the second trimester, they have to be ready, as she said, the bleeding, whether it is spotting, they need to be seen. If there is pain, they need to be seen. If they've ever had probably some surgeries, for example, something we call a lip, where you shorten the cervix, probably you're treating some form of early cancer. Or maybe they've ever had some procedures on the cervix that made the cervix weak. Or maybe they have ever lost a pregnancy earlier at around mid-trimester, that is after 13, 14 weeks onwards. They had a preterm labor, all those kind of histories given should signal the lady that she has to be very, very keen. Yeah, but by and large, all the time they have to be very careful. If they're spotting, there is pain, sort of heaviness, like going to the loo or, you know, like that, and they're pregnant, they must see the doctors so that they can, you know, rule out the issue of miscarriage.
Okay. Thank you for that. Let's go to Dr. Karen and talk about this very common one. I believe every lady as they visit you, they tell you this nausea thing. and Dr. Wachira, how can I handle this nausea, Dr. Karen? It's too much. I can't smell this. I can't sit here. I can't do this.
Nausea is so common. Very common actually in the first trimester. It's actually one of the symptoms of pregnancy.
Yeah.
So even when you watch any Nigerian movie or whatever, you'll always see the woman running because of nausea. So you know this one is pregnant.
Yeah.
Okay, so nausea is very common. It can range from mild to moderate to severe. Mild nausea, you're able to manage it at home. Not to worry, because that one happens. It's just because of the changes in your body that are causing you to have a bit of irritation in your tummy, and you have that kind of feeling of nausea. You remember there's a lot of progesterone going on in your body and a lot of hormonal changes. So a mild nausea is okay, mild to moderate, and sometimes you can just use normal ways to prevent the nausea, avoid the thing that's causing the nausea. Most of the time it's early morning. Then during the day you're very fine. So that can happen, and it gets better with your trimesters. So from second trimester onwards, it only gets better. But nausea if it gets worse, especially now if you're vomiting you're having the nausea, because nausea is the feeling of vomiting, but you don't vomit. But now when you have vomit, you cannot keep anything down. Any food that you can't look at it, especially onions. Most people will talk about onions.
Yes.
They can't have food cooking right in front of them. That now might be a problem, because we still need the nutrients. We need food, we need water to nourish your body and also to nourish the baby's growth. So now in that case, then we need to actually treat them with medication. Sometimes we give them out as outpatient. If they are able to retain a little bit of food, then people can eat kidogo throughout the day. They don't have to eat a full meal breakfast, full meal lunch, full meal dinner. They can have kidogo throughout the day, and sometimes some ginger might help a lot, yeah? Natural things can really help with the nausea. Sometimes we give them now tablets. They can take 30 minutes before the meals, and they should be okay. But now for the ones who cannot even swallow the pills, then we might need to admit them and investigate further, because there are things that can actually worsen nausea, like an infection. Also, if there is multiple pregnancy, for example, if you have twins or triplets, your nausea is going to be exaggerated. Then there's something else we call gestational trophoblastic diseases, something called a H-mole. Maybe some of our viewers might know it. It might cause a lot of nausea, which can lead you to be admitted. So we investigate those things first, and then once we find the cause, we treat the cause. If we don't find the cause, we treat it like something called hyperemesis gravidarum.
What's that?
It's a condition. Very hard words. It's a condition that occurs in pregnancy. We can't really identify the actual, it's a diagnosis of exclusion. So someone has this excessive vomiting, salivation, can't keep anything down, and we've already ruled out all those other things like the infections and all that. We treat it as hyperemesis gravidarum. But sometimes we still say those things that cause the excessive nausea might actually lead to that hyperemesis gravidarum. So the treatment is the same. We treat the cause, and then we also treat the nausea and the vomiting. And then what we want to do is to return normalcy in terms of feeding and reduction in nausea. Remember, not complete removal, but reduction. And then until we can be able to reach second trimester, which now the nausea will have improved. There's some cases of patients who've actually had nausea almost throughout the pregnancy, but most of them it's usually mild disease. Yes.
How do you handle that? I actually wanted to ask that. Can you have nausea and these morning sicknesses for the whole 10 months, as Dr. said?
No, most people it's early pregnancy.
Yeah.
But you'll have a few because if they have other conditions like gastritis, hyperacidity, ulcers, they'll almost always have a bit of that nausea worsened as compared to everybody else. So we still treat the other comorbidity.
Okay, thank you, Dr. Karen. And Dr. Wachira, can these morning sicknesses and nausea affect the baby? I'm assuming the scenario where this lady has to go and puke, for hours, then rest, takes anything, it comes out. How can that affect the baby that is growing?
Thank you very much. Just as Dr. Karen has said, it can be mild to very, very severe. And you have maternal effects, that is the things that can affect the mother, and also things that can affect the baby. When it is mild, vomiting, nausea, it's called emesis gravidarum, just some bit of vomiting in pregnancy. What she said, hyperemesis, is excessive vomiting in pregnancy, which can be a very, very serious condition. For the mothers who keep on vomiting, they have to vomit, they become dehydrated. They're not able to eat, and therefore that has a direct effect on the baby. They also will not even add weight. Therefore you see even the babies will not grow well because they not get the required nutrition. The mother is not in good health, they are dehydrated, especially in hyperemesis gravidarum. Actually hyperemesis gravidarum can even kill. Yeah, it can be a very, very serious metabolic disorder. By metabolic disorder, it means they lose some of the important bases that mop acids, and therefore it affects the heart. All right, so some of those acids can affect the heart, and the heart can start misbehaving, what we call arrhythmias, and they can actually die from hyperemesis. So in fact, severe hyperemesis gravidarum is one of the reasons for termination of pregnancies. Yes, after the doctors have sat and considered, because we have lost some mothers because of hyperemesis. So it has some effect on the mother because they'll be sickly, dehydrated, bad health, they'll be unhappy, psychologically they'll be affected, and even affect the members of the family, because they'll keep running to the hospital for dehydration, for medication. They cannot eat anything. And therefore that baby in that unhealthy mother will also not grow well.
Yeah.
Okay, they'll not grow well, so it can lead even to preterm labor. They can lead even to the pregnancy losses, the miscarriages we are discussing about. And sometimes the ones who succeed tend to get very small babies, especially if they had very severe hyperemesis gravidarum throughout pregnancy. The picture that you tend to find in such mothers who have that is that they are in and out of hospital, bed rest, fluids. They are very selective in what they eat. They see such light, and that is a trigger, because what happens in pregnancy is at the vomiting center. The threshold, there's an area in the brain referred to as vomiting center. The threshold is reduced. So anything is a trigger, including some smoking, some noise, some light. When they drive in the cars and they see things passing, that is enough. So they're supposed to rest in very quiet places and resting. So it, as she said, it can range from mild to very, very severe episodes that can affect both the mother and the baby in such ways. Yeah.
I saw Dr. Karen wanted to add something on this nausea.
I think Dr. just said everything.
And I was thinking, we have women who never experience this. They get pregnant, they enjoy their 9 months, they go deliver. So when you're talking of, then they're like, what are those? What happens to such kind of women who don't experience the morning sicknesses and nausea?
Yeah, it varies, Dr. Karen, sorry, but I just wanted to say that it's very, very interesting, because you can have their firstborn, no nausea, no nothing, and yet it's their first pregnancy. Then the secondborn, they have such terrible nausea. You try to get the things that she talked about, multiple pregnancy, those abnormal pregnancies, other metabolic diseases like diabetes, thyroid disease, and you do not get anything. So it varies from pregnancy to pregnancy, as it varies from one lady to another. And really, it is one's body and that particular pregnancy. So we do not know whether, because some have even said, casually, I think I'm carrying a boy or a girl because, I'm vomiting excessively. I think that must be a boy or a girl. So such things have come up socially. But we do not know, the reasons. I don't know whether Dr. Karen wanted to say something.
It's pretty much the same thing. Women should know that every pregnancy is different. You might have hyperemesis in this one. There's a chance you'll get in the second one, but it might not happen. So it's not very clear when and which person or which pregnancy you'll get the hyperemesis or emesis. So yeah, all pregnancies are different.
There is one more complication that I want us to talk about before we move to another one. This complication of, I don't like my husband, this pregnancy memkata. And this one has refused this one likes this. Dr. Karen, is that medically proven that a pregnancy can refuse this one and a pregnancy loves this one? A pregnany loves mango, this and a pregnancy hates potatoes.
I mean, it's been reported that people have specific likes. It can be food, it can be someone, it can be a special color or a special smell. It's all different, very, very different. I don't think we have a specific scientific reason behind it, but it's a very interesting phenomenon. For example, I usually tell some of my patients that even in pregnancy, you might like a specific thing, or actually before pregnancy, you might like to have to eat a specific food, for example, fries or tea. And then when you're pregnant, you're just not interested at all. And then the child, when they come out, maybe when they grow, they're not interested in that thing that you were not interested in during the pregnancy. It's a very interesting phenomenon, but Dr. maybe you can.
Yeah, as she said, it's quite not clear. We tend to find things called cravings, that's called pica. You find a lady would want to, to be chewing some certain stones, and as she said, some certain colors. They would want this kind of food, and all that. It's not really understood. The issue of liking the spouse or not, really. It's really a perception, I might say this, and sometimes it is good to discuss with such mothers because you see there's the issue of bonding, the baby and the father and the mother, and a pregnant lady needs support, from the spouse, the first and foremost. So it would be interesting and to discuss with such a mother, how is the baby refusing the dad? Because some of those things can reach to postpartum psychosis and depression later on. Because it will create some bit of friction here and there. So it would be important for such a mother, their practitioners, to to follow up that comment and be able to ensure that there is no disconnect.
That always brings complications in the home. And thank you for that. Remember, we are on the SMS line 22232. That is 22232. You can also get us at Hope TV Kenya on Facebook and YouTube for your questions. We are looking forward to hearing what you're saying, what your question is regarding today's topic. We are focusing on pregnancy and its complications. I think at this point, my director informs me we need to take a quick break. When we come back, we'll be getting to discuss this complication called pre-eclampsia right here on Health Check at Hope TV. Look and live.
Coronavirus COVID-19 is a respiratory virus spreading across the world. The infection is spread from droplets of coughing and sneezing of an infected person, touching or shaking hands, or being in contact with contaminated surfaces or objects with the virus. The signs and symptoms are fever, coughing, headache, body ache, difficulty in breathing. The disease can be prevented by regularly washing hands with soap and running water. Avoid close contact with people who have flu-like symptoms. Avoid handshake, hugs, and kissing. Also, protect yourself by covering your mouth or nose using a disposable tissue while coughing or sneezing. If you experience these symptoms and you had traveled or been in contact with a person from a country reporting COVID-19, you should isolate yourself for 14 days and seek immediate medical attention or report to the nearest health center. This message has been brought to you by the Government of Kenya and its partners. For accurate information on COVID-19, dial *719# or call 719. Follow us on Twitter at MOH_Kenya, at spokesperson GOK, at WHO.
From country music welcome to Activate.
It's a good morning! Good morning!
Kickstart your day with George and Kerry on the Sweet Hour of Prayer.
And welcome to Activate, this being the station where you listen and live Hope FM.
From Nairobi to the world,
Great music just for you.
Activate.
the only show that keeps you activated!
Yes, indeed.
Activate every weekday morning from 5 a.m. to 9 a.m. only on Hope FM, where you listen and live.
Every morning. With refreshing worship.
Welcome to Activate.
It's a good morning! Good morning!
Kickstart your day with George and Kerry on the Sweet Hour of Prayer.
And welcome to Activate, this being the station where you listen and live Hope FM.
From Nairobi to the world,
Great music just for you.
Activate.
the only show that keeps you activated!
Yes, indeed.
Activate every weekday morning from 5 a.m. to 9 a.m. only on Hope FM, where you listen and live.
Welcome back to Health Check right here on Hope TV. Look and Live. My name is Grace Mutiso, your host for tonight. And together with me in studio, I have Dr. Karen Muthembwa and Dr. Wachira Murage. And they are helping us to discuss this topic, pregnancy and its complications. So 22232 is the SMS line for your questions. You can also call in live. The number is right at the bottom of your screen. You can also talk to us on Facebook and YouTube. The handle is at Hope TV Kenya. We'll be checking out your questions in a short while, and we'll also be picking up your phone calls in a short while. Let me invite back the doctors, and we promise to talk about this complication called pre-eclampsia. Please, let's start with Dr. Wachira. Help us define what is it and how is it a complication in pregnancy?
Thank you very much. You cannot discuss reproductive health, pregnancy without mentioning pre-eclampsia, because at the moment is the commonest now cause that is responsible for for our mothers' mortality and morbidity, even for neonatal the same. It used to be bleeding, but now we are seeing that pre-eclampsia is so common. So this one is a pregnancy induced hypertension, just for us to understand that is a condition of high blood pressure that occurs in pregnancy. It can be mild, it can be quite severe. When you're talking about pre-eclampsia, you're saying the mother will have a blood pressure of about 140 and 90 and above. They may have proteins in the urine, okay, and they may have generalized body swelling.
What's the danger of having protein in the urine?
Protein in the urine is where now you're saying that the kidney could be involved, because we are talking about pregnancy-induced kind of a hypertension.
Yeah.
So it is not the hypertension that we get in when we grow a bit older. This is a placenta problem. Basically, let's start from there. That there are issues happening in the placenta, and what happens then after that is that you have sort of like a backflow. Yeah, so you're saying that the placenta is normally the exchange organ between the mother and the baby.
Yes.
That the mother will try and push blood for oxygen and then nutrients to the baby, and then the baby can kind of send whatever is their waste through the placenta for the mother to excrete out. So you're saying this organ called placenta has problems. Yeah, we normally say there is damage in the blood vessels in that placenta. This is the main cause, although this is the hypothesis, but this is the main pathology, that we are saying the placenta. And wherever where there's a placenta is a pregnancy.
Yeah.
So that is why we are saying is basically a pregnancy problem. So what happens is that there's sort of a resistance in that placenta. And therefore, it may set some other things called toxins into the mother, all right? And these toxins can go and damage other organs. And unfortunately enough, when it goes to the mother's body, it normally affects other organs, major organs, like the heart, the kidney, the liver, the eyes, the brain. It's actually a whole body kind of a problem, all right? So it's normally a widespread problem in the woman's body. So that kind of placenta resistance is what causes some sort of like backflow, and the mother now gets the high blood pressure, all right? 140/90 and above. Sometimes it goes to 160/110. Now you're talking about severe, all right? So the severity is normally what is the effect? What is the extent of the effect that it is causing on the mother's body and also on the baby? So that will be mild hypertension going towards severity. So when you're talking about mild, is the mother will have that kind of a blood pressure. They may have some headaches, some swelling, here and there, especially of the body.
Yes.
Remember, we do not look at the swelling of the ankle area. That is common for mothers. They kind of will have swelling around the ankle region. We are talking of generalized body swelling. So that is mild, pre-eclampsia, the PET, and you are able to manage that mother until they deliver. When you're talking about severe,
yes,
you're talking now the blood pressure is quite high, 160/110 and above. You're saying now the mother has other symptoms like very severe headaches. They may have even severe abdominal pains. That means now even the liver is involved. They even have now what we are calling acute kidney injury, because the kidney is involved. And that is now where the proteins are involved. You're talking, we normally say +1, +2, +3, depending on the extent of the kidney injury. So when you're having +3 and above, you're having a blood pressure of 110, 160/110. The patient has blood vision, very severe headaches, that severe epigastric pain. We are talking now of a very severe pre-eclampsia. And that point, the doctor is thinking of delivering.
Yes.
Because in a nutshell, to summarize, is that the treatment for pre-eclampsia, that is the PET, is delivery.
At whichever
At
point.
whichever point.
Yes.
So you're saying it is mild, therefore you can continue with it because it's not affecting the mother as such or the baby as such. But when you're talking about very severe, then it means for you to remove that scenario of the pre-eclampsia, then you have to deliver the patient. So it's normally a balance for the doctors and the clinicians, Dr. Karen and I and our teams to decide that the mother have severe pre-eclampsia, they're having this severe blood pressure, they're having this epigastric pain. You know, the kidney is being affected. They cannot see properly, all right? So what do we do, all right? You try and control all those, but they are not working. Then at whatever point it is, that's where now we deliver the baby.
Yeah.
Yes.
It's a very dangerous condition there.
Yeah.
Dr. Karen, you want to add something?
I'll just add a bit on the severity of that preeclampsia. There's something called eclampsia now. That's when someone or a pregnant woman actually is affected. Most of the time it's all the organs, most of the organs plus the brain, so they have a fit. So this eclampsia, when you have it, we have to deliver the patient, whether the baby is term or not. We still have to deliver the baby. Yeah.
Okay.
And also to add on something
Yes.
that Dr. Karen has made me remember is that we would want to probably mention for the sake of our viewers that what are the risk factors? Because there are some ladies that are more predisposed to preeclampsia.
Yes.
Let me start by saying as long as you are pregnant, you have a risk factor of having preeclampsia. Being pregnant, when it's a first pregnancy, there's a higher risk. People carrying twins, right, stand a higher chance of preeclampsia. People with other diseases like diabetes, pre-existing hypertension, okay,
Yes.
they do stand a higher chance. So any other medical conditions, especially diabetes and thyroid disease, hypertension, stand a higher chance of preeclampsia. Very young, very young patients like teenage pregnancy also stand a higher chance. Older mothers, 35 and above, they also stand a higher chance of preeclampsia. So there are those groups of high-risk mothers
Yes.
with more risk factors that we shall advise as doctors that we need to be on the lookout. But by and large, as long as one is pregnant, we need to look out on those symptoms of preeclampsia and be able to manage. We normally even say, as we are managing preeclampsia, then we are thinking ahead of the disease, that this mother might need to deliver early. So what kind of hospital are they going? Where there's a good nursery, because we might deliver the baby before it's due time, and therefore the baby might need nursery. Sometimes, as Dr. Karen has said about the severity head of preeclampsia, the eclampsia,
Yes.
which has fits, most of the time is an ICU condition that needs a patient to be in ICU. So there are all those factors when you're managing that patients, and our listeners should know that whenever they have been told they have preeclampsia, then they need to align themselves in a sort of a birth plan to know the kind of facilities they'll be attending during their pregnancy.
Apart from the pressure shooting so high, is there any symptom that a pregnant mother needs to look out for in relation to preeclampsia, Dr. Karen?
Yeah, it's just the symptoms Dr. has talked about in terms of if you have headache, any dizziness, sometimes that might be an indicative thing of hypertension or preeclampsia. If you have pain around this area of the stomach, we call the epigastric area, or towards the right side, that might also be a sign that you're having preeclampsia. The body swelling, it might be all over from the face to the hands, not just the ankles, because that one is very common. So that can also be a sign. But remember, hypertension most of the time might not have symptoms unless it is severe. So by the time you're having those symptoms, then it could be on the severe preeclampsia side.
Okay, thank you for that. Allow us to check a few questions that have come in from our great viewers. Then we'll get back. I'd really love you to talk about pregnancy and COVID, because we are living in the COVID season. Yes. But one of our viewer writes and says, "Hello, Health Check. What causes hemorrhoids or hemorrhoids during pregnancy. I have suffered throughout, now in 3rd trimester, so much gas and bloating. Please help.
Hemorrhoids are normally anal swellings. They are also called pious. And basically they are damage to the blood vessels around the anus. The anus is is rich in blood supply, and wherever there is some sort of pressure, like in pregnancy, overweight, okay, anything like delivery, like a difficult delivery, because of that pressure, those blood vessels kind of dilate, they enlarge, and that enlargement is sort of permanent. Okay, yes. When there's that pressure, it's like empty pockets. They fill in sometimes, sometimes they empty. During pregnancy, those spots, and also during constipation.
Yes.
Yeah, they may have mild damage to blood vessels, so they form those pockets. So in pregnancy, it's just an issue because one is pregnant and there's lots of pressure. The blood you fill up. And when it fills up, then it means that it will be swollen. Normally, there is not much you do. If there is a lot of pain, then you have some analgesics or painkillers. You may have something to apply to soothe, the pile or the hemorrhoid. Other times, it might need surgery, even during pregnancy, because it can swell and actually start bleeding. It can swell and become very, very painful. Yeah, so in those instances, surgery might be required. But in most cases, what we do is that we teach the mother about the diet, veggies, fruits, lots of water. We may give them some medicine to soften the stools, to soften us, so that they pass off their stool with ease without having to stretch and force, because that is what now worsens the hemorrhoids.
Okay.
Yeah.
Yes, Dr. Lillian, that's okay.
It's just an addition on
yes.
blood vessels as well, in terms of how they also flow back. There are people who also experience things like varicose veins, which might also go with this pretty much the same principle. So if you have those small veins on the thighs or on the calf area, the same thing, those blood vessels fill up with blood, because the return has been reduced because of the pregnancy. So with this kind of situations, most of them after pregnancy, they usually resolve. So it only gets better after also delivery.
Okay. Another listener asking, which I'd love Dr. Karen, to handle. Lillian is asking, kindly help, the milk disease, is it connected to miscarriage?
The what?
Milk disease.
Milk disease.
Ugonjwa wa maziwa.
Brucella. I mean, there's, I talked about septic abortion, and it's any infection can cause a miscarriage. But it's not necessarily that brucella specifically will cause a miscarriage. It's easily treatable if it is actually there. But you have to remember that if you have severity of any disease, it can actually cause some miscarriage. Yeah.
Doctor, you have anything else to add?
Just as Dr. Karen has said, when we were talking about causes, remember we mentioned things like genetic, we mentioned things like the placenta and the progesterone. But when a lady tests to get recurrent pregnancy, cirrhosis or miscarriage, then we think of something that is there. And this is when we think about infections, where now the brucella, whatever they are calling the milk disease, is involved. And this is how we talk about infections we abbreviate as TOCHs. Toxoplasma, rubella, chlamydia, syphilis, others called CMV. Those are a group of viral diseases, and they're infectious that cause recurrent miscarriages. And we tend to check them and do, although they are rare. We are now finding some patients coming up with those brucella and those other diseases as a cause of recurrent miscarriage. So the milk disease can actually cause recurrent miscarriage.
Okay. Dr. Karen, this one is asking, happy to be part of this forum. Thank you so much, Rachel Daudi. And she's in the third pregnancy, but I have a lot of pain around my waist and a persisting sneezing that I didn't have? Kindly assist.
Okay, that's a very good question. And I'm assuming maybe in her first and second pregnancy, she didn't have that specific pain. And we said they're all different. The pain that any woman can have around the lower waist and around the back, and it's very common with most women. Sometimes they have that pain because of the relaxation of those muscles, especially when the baby is heavier. You know, as they're growing, they're becoming heavier and heavier. So there's that pressure they put down there because of gravity. So there's a lot of pulling and pushing of joints and muscles, and even the bones are relaxing, and also the tendons around the bones, they're also relaxing. So they might actually experience some pain in the lower abdomen, the hip area, and even sometimes some pressure down there. For the sneezing, there's also a lot of space. The space that was in the abdomen has been taken up by something that's growing, and it keeps pushing up the diaphragm and affecting the respiratory system. So they might actually be having some people might have hiccup, or they might have even problem breathing, especially when they sleep downwards, because of that pressure on the diaphragm. But you have to remember that even sneezing could also be a simple allergy, which could have been aggravated during the pregnancy. There are other things that can cause the pain at the lower abdomen and the waist. If you have a urinary tract infection, or you have any issues in your bowel, you might have, instead of feeling the normal pain when passing urine or whatever, the pain might just be located on the lower abdomen. So it's important to still see the doctor, get them examined, let them do the normal tests, the urine, check whether there's any issue. Then if there isn't, then you can reassure her and tell her it will be fine, painkillers will do.
So it is important that, as Dr. Karen says, that they indeed have to see the doctor, because when we label it as a pressure pain, we are saying it's excrusion. All right, so you have to rule out those other many things, do a scan of their fibroids, maybe able even to do a vaginal examination to ensure that it is not premature labor. So it's only that then you can reassure them, probably put them on some analgesics, some sort of bed rest. These days we even have some mothers that have so much pressure pain, because some pregnancies tend to sag, on the anterior part near the bone, and now we can have some sort of pregnancy cradles that some mothers have, can be given by the physiotherapist to be able to support the pregnancy. But it's only after, as she has said, they have seen the doctor and ruled out other known causes, then they can have those other treatments.
Okay. And remember, our viewers, you can call in live. The numbers are right at the bottom of your screen. We are looking forward to picking your phone calls and answering your questions. Our great doctors will be glad to help you, in addition to the SMS line 22232 and at Hope TV Kenya. Dr. Wachira, this one is for you. Why should a pregnant lady experience cramps in her early stages of conception? It's a gentleman writing.
That's very interesting. Yes, we can have cramps in the early stages of conception, especially in the first trimester. Sometimes we say that the uterus is carrying something. It was not used to carrying something.
Yes.
Right? So the uterus can start contracting. There are various reasons. That's number one. That the uterus, is now gravid. It was not gravid. So sometimes we have to have some mothers who are sort of cramping. You have what we call premature or some sort of ectopic contractions. Sometimes you do an ultrasound and you find the uterus is contracting, like it sort of wants to expel that pregnancy. It can also be a reason for a threatened abortion.
Okay.
All right, because we don't know why the uterus is overexcited, why it's really contracting, and many a times you want to give some treatment, some bed rest to do that.
Okay.
Having said that, as you said earlier, is that you must be able to rule out other now known causes that can be a problem.
Yes.
And that is maybe the cervix could be opening.
Pause there, Daktari, on the point of cervix might be opening. Bridget is online. How are you doing, Bridget?
Fine.
Thank you for calling Health Check. What's your question?
My question is,
Yes.
I'm 2 months pregnant, Hello?
Yes. Go on,
I'm
Bridget.
2 months pregnant, but I keep on vomiting. I can't eat. I can't cook. Hello?
Yes, keep
Yes,
asking.
Bridget.
Yeah, I can't. By the time I feel like eating, I vomit. Before I cook, I vomit. It's like all day. So long as I'm out of the bed, I'm vomiting.
Okay.
What should I do?
Okay.
And I have a
thank you.
pressure at the lower abdomen.
Okay.
Okay,
Yeah.
Bridget. Yes, sorry for that you're not able to do what you love most, to cook. You
Yeah.
cannot get out of bed, but it's the nature of the pregnancy. Keep moving, it's for a good cause. The vomiting is due to hormones. You have progesterones and estrogens that are they are a lot in your system from the placenta. Those are the ones that are exciting your vomiting center and make it have a low threshold. So any small trigger makes you feel like vomiting. The smell of the nice food that you used to cook, again, it's now terrible. You don't want to perceive that nice smell, of eggs and, those nice things. You see nice Fanta, orange, the color itself puts you off. It'll go away. It will become less. Some people continue and may have it throughout pregnancy, but as doctors, we are there to help you. We will guide you in terms of let someone else do the cooking for you, so you stay in a secluded area, quiet area, and then be choosy on what you eat for the time being. Things that do not cause a lot of vomiting for you, most of the time are unfortunately the dull things, the things that are not fried. Those are the things that time now will be more exciting. If you go for the soups and the eggs and the meat, you'll be in lots of trouble. So that is what you do, and then you have some medicines to help you. But understand, in other words, Dr. Karen and I, we might say we are happy that you are vomiting because your pregnancy is good.
Alive.
It's alive. Because again, if you are saying me, I was told I'm 2 months, but I can't feel anything, we get worried because we think that the pregnancy is not producing hormones. So it's still a blessing in disguise. But there are those treatments we give. There's some medications that your doctor can give you to help you in vomiting and some rest, and be choosy on foods, you'll be okay. The issue of the pressure and the pain again is a pregnancy. There's some weight in your pelvis, and therefore that's why you feel that. But as your doctor check your cervix to ensure that the cervix is intact, there's no urinary infection, it is basically the pressure of the pregnancy, and then you'll move on.
Okay. Thank you, Bridget, for calling. Kwamboka is online. How are you doing, Kwamboka?
I'm fine.
Thank you for calling Health Check. What's your question?
Yes, I have a question.
Yes.
I'm pregnant
Yes.
with 33 weeks, but I have a problem in my abdomen.
Yes.
Hello?
Yes. Where exactly in the abdomen?
Down the abdomen.
Okay.
Yeah.
So
Okay.
we have
I
gotten.
keep on feeling the pain throughout the night. But when it reaches the morning, I become fine.
It becomes?
Becomes fine in the morning.
I become fine in the morning, yeah.
Okay. So the pain sometimes what you're feeling down there is because most of the time it's because of the baby's weight. But we have, as we have discussed a bit earlier, that if you have any pain down there, it would be good to get checked and find out whether there's any issue that's causing you to have that pain. It would be good to have an ultrasound, a urine test done to rule out any infection or any abnormality huko ndani. But otherwise, if all that is okay, that weight of the baby might cause you some discomfort as you continue on in the pregnancy, but after delivery, it's going to get better. So the issue about the pain mostly at night and in the morning it's gone, it could also be because of the position you're lying. Sometimes even the pain threshold is usually a bit lower at night in a way that you experience pain more at night than during the day. So what I can tell you is if you haven't gotten checked yet, it would be important to just at least get your gynecologist to check you first. And then later on you can, if everything is okay, then you might get some painkillers here, but it will get better with time. Yeah.
Thank you, Kwamboka, for calling. We have another call online. Hello.
Hello.
Thank you for calling Health Check, sir. What's your name and what's your question?
My name is Jeff Nala.
Yes, Jeff, what's your question?
My question, I'm calling on behalf of my wife.
Yes.
Now she has delivered. The baby is now 2 weeks.
Yes, go ahead.
And but now she's having challenges of bleeding still. And the baby is also having a difficulty. Like now, the whole from 4 a.m. today, he has not slept because it is like an issue. I don't know whether it's the stomach or what. So I'm wondering what might be the challenge. Is there medicine to be given or what? Yeah.
Okay.
So the two questions. One for my wife, she's still experiencing some bleeding. And then the baby is having uneasiness, like the whole day he has not slept.
Okay.
Yes.
Thank you, Jeff. Stand by. Doctors will be answering you. Let's pick this one, then we can tackle the two.
Okay.
Hello. Okay, we've lost that one. Madam Director, you have another call? Okay, thank you. Let's sort Jeff. The wife still bleeding and the baby has not slept since 4 a.m. Oh, that must be tough.
Yes.
Okay, Jeff, thank you so much for coming through for your wife. We like such husbands. There is a pattern of bleeding after delivery, and that is, we normally call it lochia loss. The bleeding that comes, the discharge that comes after delivery, we call it lochia loss. And initially, like for the first 2 weeks, you tend to have like red bleeding. Right, and then after that starts to reduce in amount and also changes color to about a straw color, some light yellow and something like that, and then grayish, and then it will dry. So you can have light lochia, heavy lochia. So as you mentioned earlier about the use of pads, if you find that you have frequently changing the pads and they are fully soaked, or the bleeding is coming in clots, that is a concern. But if it's only one pad, or two in 24 hours, that is the normal lochia loss. Right? You should not have a bad smell, you should not be heavy in clots, and you should not change the pads many times. If that happens, then you must be able to see the doctor, because that is now what we call postpartum hemorrhage.
Yeah.
And the causes can be many. Maybe some portions of the placenta remained inside, maybe there was a tear somewhere. You need the doctor to check and understand why are you having that late postpartum hemorrhage. That is the name given to that. For the sake of the baby, it looks like the baby is a bit stressed. Either the feeding has an issue, all right, or maybe they are getting some cramps because of maybe the protein in the urine, or maybe there's something going on. So a baby that is distressed and has not slept since 4 a.m. and it's now almost 12 hours plus, now it's a baby that needs to be seen. Yes. Because it could be a sign of something.
Okay. Esther is online. How are you doing, Esther?
I'm good.
Thank you for calling Health Check. What's your question?
My question is, last year,
yes,
I had a miscarriage December.
Yes, go ahead, Esther. We are listening.
I had a miscarriage December. Then this year on this last month, I had a 2-month pregnancy. Then I got a miscarriage.
Yes.
Because of it, what might be the problem?
Okay. Thank you, Esther, for calling, and we are sorry about that. Dr. Karen?
Okay. Sorry, Esther, about that problem. Lately, we've seen quite a bit also on miscarriages. And as we had discussed, there are different types of miscarriages. But there are people who might have one. We are not as worried as if it has repeated itself. As we said, most of the time, the reasons why someone might have a miscarriage might be because of this progesterone. Maybe the progesterone levels did not rise as they should have during this first and second pregnancy. So the issue of hormones might be an issue, and that's important for us to find out, and that's why we start on progesterones early, especially for her. Another thing, these things about genetics and how the pregnancy started to form, if it doesn't form very well, either due to some deficiencies, so like we really look out for folic, something called folic deficiency. We really advocate for people to start antenatal early, or even start folic before they even get pregnant, because a deficiency can also cause genetic changes while the pregnancy is forming. Another thing is that thing, Dr. You talked about infections, like the torches. Those infections, if there's a recurrent miscarriage, we have to look out for them.
Yes.
And they're important. It's important for us to find out whether they have any viral issue that needs to be sorted out. Another thing is even the blood type. You've heard of cases where people have different blood group, rhesus negative and all that. If you have a rhesus negative blood type and it has not been managed in your previous pregnancy,
Yes.
assuming this is maybe if she had had one child and these are 2 pregnancies after that one child, maybe that could have been an issue at the time. So them, and also other conditions like diabetes, if your sugars are not well controlled. So other comorbidities might be the reason. So it would be important for such a patient to start antenatal even before she gets pregnant.
Okay.
So it would be important to start early with the doctor, get your blood works checked. We'll check for infections, we check for your blood type. It will start you on folic, we'll start you on other supplements if need be, and then you can now try to get pregnant. And also the time in between pregnancies.
After miscarrying.
Yeah, after miscarriage. It depends also on whether you want to get immediately or not, because we can't really tell a woman, don't get pregnant after this miscarriage. We can only advise that it would be good to at least space the pregnancies, allow the uterus to heal, and then get pregnant. So that would be important.
Okay.
Yes.
Thank you. Brenda, you're online.
Hello.
Hi, Brenda. Thank you for calling Health Check. What's your question?
So what I was asking,
Yes.
is there any symptoms, any signs that can specify the gender of the baby?
Ah.
And then the second question,
Yes.
if the blood group is the same with the husband, can it affect the baby?
Okay. Thank you, Brenda.
Thank you. Yes, this is a very, very common question, but there's no really signs that can tell us the sex of the baby. It's either an ultrasound that tries, the doctors, when they do an ultrasound, they can see the genitalia, the organs, and they can be able to confirm for you. So there is no timing. Some people say, oh, when the husband comes like this, oh, they're in this state, when you eat this and that,
Yeah.
all those things, they're just perceptions that people bring forth. The blood group issue is, as Dr. Karen had mentioned before, is rhesus negative. We are talking of a mother who is blood group negative, either A, B, or AB, O negative. That negativity is normally what is the issue when the husband is positive.
Okay.
But if the husband is O negative and the wife is O negative, that is fine. If both of them are A positive, that is fine. But if the mother is negative and the husband is positive, that is where now the issue of the rhesus, immunization, that is now where we come in to try and sort out.
Okay. I'd love us to talk more about that. We have another call online. How are you doing?
Hello.
Hi.
I'm doing good.
What's your name and what's your question?
I am Lizzie,
Yes, Lizzie.
and I am 5 months, 2 weeks pregnant.
Yes.
And during the night, I have a problem while I'm sleeping. let me say it in Kiswahili, mkono inaganda, my right hand side inaganda, and it will take me to sit down so that nikinyorosha hivi kidogo it becomes normal. Yeah, especially the right hand. And during the day, you will find that it is so painful. I cannot lift something that is heavy. You can see the veins. When the pain is there, you can see the veins, and it's only the right hand side. Yeah.
Okay, thank you, Lizzie, for your question. Dr. Karen?
Thank you, too.
Okay, hi, Lizzie. Oh, she's off.
Sorry, Lizzie. Yeah.
Okay, so when it comes to pregnancy, sometimes you can experience numbness in different areas of your body. It could even be the feet, it could be the arm, it could even be just the wrist area. There are many, I mentioned earlier that because of the hormonal changes and all that, you have also some muscles tending to relax, and you have tendons that might become a bit problematic in some areas of your body. Again, even the way she's sleeping in her bed, she might be sleeping on that side more often than not, and she might have to remember to change positions or elevate that arm, specifically on that arm. I don't know which part of the arm exactly, is it the end of the arm or what, but sometimes the wrist area, you'll find there are people having that a problem with the wrist because of some tendons around that area, and also the swelling because the pregnancy just makes you sometimes have a bit puffier fingers or puffier, so which might also limit the blood supply and cause that tingling and numbness, and you even see the veins around those areas. Yeah, so it would be good to at least even see a physiotherapist who might help them exercise that arm. When they're sleeping, they can change positions, they can try and remember, maybe ask someone to remind them to turn and elevate that arm. Yeah.
Okay. Yeah. We stopped somewhere, Daktari,
Yes.
Dr. Wachira, about cervix opening. You were giving an explanation to that.
Yes.
And also, I would love you to wrap it up in a minute or so, then we tackle a question. And also, rhesus factor, I wanted to ask, should couples just walk in and be tested, or it's something the doctor has to prescribe for you to know that we are compatible when it comes to the rhesus factor?
Okay, thank you very much. When you're talking about cervical incompetence, this is a condition we find coming, especially after the first trimester, from 14 weeks onwards. And the cervix normally just gives way. If you look at the descriptions given by the radiologists, they normally say there's funneling. You know the funnel that normally you put some liquid in?
Yes.
It's kind of like a triangle sort of. So the cervix is supposed to be tight, but when it funnels, it kind of starts to open. It is loose, and therefore it gives way for the pregnancy. It's very characteristic because it's painless opening of the cervix. The woman will just feel some weight, yeah, and then after some short time they may feel something drop. If not that, they may feel some water, the rupturing of water. It's sort of a very painless because it's something opening slowly because the cervix is weak. And normally the pregnancies are normally alive. Yeah, you find that it's a small fetus, but it will show signs of life. Yeah? Of course, they will not survive after that. So we able to diagnose cervical incompetence from the history. Yeah? History of any cervical operations, dilatations, history of any such pregnancy losses at that particular time. And they're normally on a reducing gestation. So if the lady lost at 20 weeks, this time the other one they lose at maybe 16 weeks or 4 months, and like that. That kind of a reducing, because the cervix is continuously becoming weaker and weaker and weaker. And we have a treatment for that. What we do is that by the first trimester, just at the end of first trimester, or before the time they lost that other pregnancy, we normally put a stitch, and tighten the cervix, which we normally remove when the pregnancy is mature from 37 weeks of gestation. So it's something that keenly observed, keenly diagnosed. The woman should not lose any more pregnancies because of cervical incompetence.
Okay. And the rhesus factor, you wanted to add something, Dr.
Yeah, it's on the rhesus.
Yes, please. Yes.
It's always advisable for every couple to at least attend clinic before even they get pregnant. So that's usually, I personally, I always tell people to go to the hospital first and get themselves checked. But not to worry, you know, because you can't tell someone to now separate because one has rhesus negative and the other has rhesus positive. We're not worried if they have the same blood type, as Dr. has said. We are only careful if the mother, not the father,
Yes.
the mother is rhesus negative. Why so? Because rhesus negative, it means you don't have that rhesus protein or factor in your body. So if you have a baby inside you who has rhesus positive, because the father is rhesus positive, you start to form jeshi, like ascaris, to fight that new thing in your body. So that's what we don't want. So that's an immune response by the body. It's normal response. So what we do is, if we know that you're rhesus negative from the beginning, at some point when you reach around 28 to 32 weeks, we usually do a test to find out whether they are jeshis already, not the white cells that are supposed to fight that baby. If there isn't, we give you some medication, and it's usually called anti-D, just to hide or close the eyes of the jeshis, not to see the baby. I hope it makes sense. I'm trying to make it a bit.
The baby.
Yes, not to attack the baby. And the first baby might be okay, because by the time the jeshis have already formed, the baby might have been delivered. The second baby might not really be lucky. So it's important, even before you get that first baby, let's just find out. We always do the blood group, and the things we do together with the partner. So yeah, it's important to know, but not to tell you to separate. No, it is okay.
Okay, please visit the doctor. I'd love us to tackle 2 or 3 more questions before we wrap it up. And of course, COVID and pregnancy still at the back of our minds. I gave birth last month, my firstborn child. I would like to know the best family planning for the person with varicose veins.
Family planning methods, normally how we do it is that someone has to visit us, and then we're able to explain and take them through, because we have hormonal and non-hormonal. So when you're talking about varicose veins, we'd want to do as much as possible less hormonal contraceptives. And therefore we go for the non-hormonal group, which the prominent member here is the copper-based IUCD, or the coil. That is normally very good. Then of course you have barrier methods, you have natural methods, and if they are happy with their family size, sometimes we can advocate for permanent method. So a person with varicose veins, we discuss more on the non-hormonal column.
Okay, this one is for Dr. Karen. How do I stop severe itching down there? Been to hospitals twice, and they say it's overproduction of yeasts. When I get treated, it stops but comes back after some time. It's very uncomfortable. 3-4 weeks now. Can this affect my baby in any way?
Very good question. Candida or yeast infection is very common in pregnancy because of the immunity. Your immunity is just slightly reduced, so you get things like urinary tract infections and candida really gives a very annoying itch down there. So it's understandable that it's annoying her and irritating her. So the important thing to do here is to actually treat the candida. It has been treated before, but if it keeps coming back again, we need to find out which exact antifungal, it's a fungal infection, will work on that specific candida infection that she has. So it would be important for us to take a swab of that discharge, if she has discharge, and take it to the lab, find out what whether it is actually candida. It's one thing to just treat without looking for it, but it's also another to confirm that it is candida that's causing it. And then we give it some medication in the lab. Whichever medication works, we give it to her, and it might be for a longer time as compared to if it was just once, because she seems to have recurrent candida infection. Whether it will affect the baby, no, not necessarily. it is just it's for around the vagina. But if she has spurious candidiasis during delivery, it might actually infect the baby during delivery if it's a vaginal delivery. So it's important to be treated, and especially for her, it might be a longer treatment session.
Okay.
Yeah.
Dr. Wachira, I promised that will help expectant women together with Dr. Karen, especially in this season of COVID. So what are the do's, the don'ts? What are the symptoms? You know, our first list viewer said sneezing, and you know sneezing is... So what should expectant mothers look out for in a minute before we wrap it up?
Thank you so much for that question. We like to assure the viewers that they should not stop getting pregnant. They should not be scared if they had planned to have babies. They should not stop their projects. Let them have babies. Having said that, the symptoms of a pregnant mother with COVID is just like, you know, anybody else. You know, there's the cough, the sore throat, the fever, the headaches, the joint pains, all those. But what we are doing, or what the hospitals are doing, is they have put those necessary measures to ensure that we protect our mothers. As the mothers are coming to the clinic, of course, we expect all of them to be on mask as they visit the clinics. As soon as they are coming in, they are washing their hands, they are sanitizing, and there's a thermal gun. If they have fever, then they're not allowed. They have to be set aside, and then they have to be sent for a place to do a COVID test first to ensure that they are COVID negative. And if they have, of course, the symptoms of cough and sore throat, they have come from abroad, they have to undergo that assessment to ensure that they don't have COVID. Once they get through that kind of a checkup and they're in the clinic, then of course there's the distancing, minimum 1.5 meters. So that one is observed. And when they're in the doctors, of course, now as doctors ourselves, we also protect ourselves and protect them by having masks, and we are putting other, gowns, to protect ourselves, and some are even putting shields.
Yes.
All right, and then you examine the mothers as usual. All right, and discuss the things. You are keeping distance, you have mask, and after every procedure you're washing your hands and you're sanitizing. And the patient, also the mother, is doing the same.
Yes.
Yeah, they wash their hands and sanitize. And then from there, then they go out of the clinic, they collect their medicine, and they go. One might want to know during delivery.
Yes.
Yeah,
in a minute, Doctor. In a minute.
Yes.
Yes. So what happens?
So what happens? Yeah. So when they are coming into the delivery rooms, the same things are done. They are coming with the masks. Okay, the observations, the distance between the health personnel and them is maintained. Yes. The health personnel is protected with the gowns, not necessarily PPEs. Okay, if you are coming and you have no symptoms, you just do those things: the mask, the distance, and of course the usual, doctors' gowns that they are putting. And then in the labor wards, the distance is kept.
Yes.
These special patients who comes and they are suspects of COVID. Maybe they have the temperature, they have the sore throat, they have all those symptoms that we have alluded to. Then those ones will be treated in a sort of an isolated area. Okay. That's where they labor, and they go into a sort of, a different delivery room.
Yes.
And once they vacate those 2 rooms, then those 2 rooms are fumigated and given some time for that fumigation to take place. If a mother turns out to be COVID positive,
yes,
we do the same things, right? In the first stage, what we call first stage, where they're laboring, is special, they deliver, fumigation, and then after they deliver, they go now to an isolation place, where now the staffs are different. They have the PPEs, right? And then they are managed there by a special COVID team that has been trained to handle them, and they go with their babies.
Wow, that's interesting.
Yes. And
so they are assured they'll be fine.
Yes, they'll be fine, and they are treated. So that is how we are handling it.
Thank you so much. Our time is up. We appreciate you for coming. Where can we get you, Dr. Wachira?
Wachira Murage is based at Savannah Healthcare Services.
Okay.
We are on Kenyatta Avenue and in Upper Hill, Mara Road. And of course in Kenyatta National Hospital, we are also there.
Okay.
Yes.
Dr. Karen.
You can find me in Kenyatta, but you can also find me in town, IPS building, first floor, Thorntree Healthcare.
Okay. Yeah. Thank you so much for coming. We appreciate you, and we appreciate your viewers for your great time. My name is Grace Mutiso. Wish you a blessed night. See you next week, God willing. Goodbye.